everybody. Welcome back to the Core Consult RX podcast. My name's Mike Corvino. With me, as always, Cole Swanson. Cole, what is going on, man?
Nothing much. Doing great. How about you?
Can't complain.
Yeah. Pretty pumped that we're talking about maybe both of our favorite topic, you think?
Yeah, for sure.
Diabetes management.
Correct.
Pretty
I would
excited.
definitely, I would say top three at least.
Top three at least.
Yeah, probably favorite.
I enjoy it.
Yeah. Plus, it's probably the thing that I know more trials and things like that with, so it makes me feel smarter than I actually am.
There's a lot of evidence out there.
Yeah.
Yeah.
It's good.
Mm-hmm.
It's good for my ego. So, we've talked about, the diabetes guidelines and kind of compared and contrasted those. We've talked about some of the different treatment options. We talked about GLP-1s in the past. But today we're going to really focus on a GLP-1, specifically Semaglutide, and the trial that looked at its cardiovascular, outcomes. So ended up being cardiovascular benefits, but they weren't really sure what they were going to find when they started it.
Right. So we're actually going from macro level, which is what we usually do, and going a little more micro, which will grab bits and pieces of other diabetes concepts within that. But I think it's cool to take a trial and really flesh it out in this one drug in a class in a very complex disease state. Some think it's complex, some think it's pretty easy. I think it just depends on how much detail you get into it, but to each his own.
So we told you we were going to do it. You didn't believe us.
Yeah.
But here it is.
Finally.
Maybe. We'll try and stay on task.
But yeah, so the point of, he mentioned cardiovascular outcomes, cardiovascular safety, a little background on these types of trials that you see a lot in diabetes. And of course, you see similar types of safety trials in chronic disease states like heart failure, hypertension, that sort of thing. But back in 2007, the FDA said, hey, anyone who wants to make a new diabetes drug, and even some established diabetes drugs, if you want to get our, official heart seal of approval, you're going to have to perform these cardiovascular safety trials. And so that's what they started doing. And it just so happens that a few of them in their secondary analysis were like, hey, this isn't just safe compared to placebo. This is actually better than placebo as far as reducing cardiovascular events. So Sustain 6 is one of those.
Yes. So we've been through this before, but just as a refresher, let's kind of talk about GLP-1s real quick.
You can never have too many GLP-1s. You can't have too much of it.
That's actually the bumper sticker on my car. You can never have too many GLP-1s. All right. So mechanism of action. First and foremost, obviously we have GLP-1 receptors kind of located in various places in the body. So the main one we think about with when we're treating with especially type 2 diabetes, in the pancreas, when GLP-1 binds, it's going to cause beta cells to start producing insulin and hopefully drive that blood sugar down and where it's out of the blood and where it's supposed to be inside the cells. So the first thing to kind of think about is it's not like a sulfonylurea where it just will bind and automatically start pumping out insulin.
Exactly.
Causing hypoglycemia if the person doesn't eat or whatever. But this one actually will only start working whenever the patient consumes carbs. So that's one really good benefit. We have less likelihood of having hypoglycemia typically, unless we're using it with insulins or something like that. But the first step, it's going to release that insulin, and so the sugar, the glucose that's in the blood, will then be transported inside the cells to be used for energy.
Right.
Fun fact, just so you guys all remember your early biochem days, but
so much fun.
Yeah. So whenever the glucose is transported into the cell, the first step of glycolysis, if you remember, is hexokinase converts it to glucose 6-phosphate. And the reason for that is when you add that phosphate group, it is not unable to leave back out of the cell again. So it's kind of trapped, and then it continues on its way to all the way to pyruvate and then into the Krebs cycle and electron transport chain, and the rest is history. Lots
all
of ATP.
That good stuff. Yeah, that's not just back to med chem. That's back to 9th grade biology right there.
Whoa, that was at least a 10th grade level.
Yeah, I mean, we're going micro.
Okay.
We said we would, and we're doing it.
We're doing it. Man, we're honest.
But yeah, GLP-1 generally, it's glucagon-like peptide 1, but it's one of the incretin, or as my southern friends like to say, incretin hormones. I don't know how to say it.
It's incretin.
Right. plays a large part in that cycle that he's talking about in diabetes in general. So that's why we give it.
And, at the same time, we have this beta cell production of insulin. We also are going to suppress glucagon production. So it's going to affect the alpha cells, and they're not able to produce glucagon. So when you are stopping glucagon production, you are going to stop things like gluconeogenesis. You're going to stop glucogenolysis. And so the patient's not going to be producing even more glucose to be released. So also another factor is that glucagon inhibition. They're kind of working simultaneously.
Right. And so that's its primary mechanism of decreasing sugar. It has a couple of other things that it does, primarily for weight loss. So that's another positive that we talked about with GLP-1s, whereas sulfonylureas, insulins, and others may cause weight gain. You can actually see weight loss with GLP-1s. One, they slow gastric emptying, and so that kind of tells you what kind of side effects they're going to have, maybe similar to a mild gastroparesis picture, because you're basically inducing gastroparesis through that, but it does help with weight loss. And then they're also going to promote satiety by acting on the hypothalamus, so increase that feeling of fullness, so you basically won't eat as much, which is going to promote weight loss overall.
I think in the hypothalamus, they decrease the firing of those pro-opioid melanocortin neurons.
There you go.
I memorized that word a long time ago, and for whatever reason, it's always stuck in my brain. I think that's...
Now everybody gets to remember it.
Yeah. It's fun to say.
Pro-opioid melanocortin.
Mm-hmm.
I like that.
Neurons. Yeah, me too. Makes you sound, again, smarter than you really are.
Smarter than you really are.
Perfect.
I should mention some of those side effects being nausea, especially, and some vomiting potentially. It can be significant and happens in a lot of patients, but it's transient. So if they can push through really that first week or so of being on these medications, semaglutide being one, it should go away over time. So if the patients aren't warned about that up front, they're probably going to stop using the medication.
Yeah, and especially if you have a patient that is, I've seen this too, where the patient is being started on 2 meds at once. They're put on metformin, immediate release, and then also on a GLP-1. So, yeah, it's going to be
tough on the tummy.
Some GI discomfort.
Oh, yeah. So, that being said, we're talking about semaglutide, brand name Ozempic, some other ones being Victoza, which is liraglutide, Bydureon, which is exenatide, and there's also Byetta, which is the immediate release, and then lixisenatide, what's the brand name of lixisenatide? Adlixin, yeah. Also Trulicity, dulaglutide. So those are some of the big GLP-1s that you'll think of. I think there's a couple other ones too, but those are kind of the main ones.
Tanzium, albiglutide is, I think there's a few hanging around still, but I think by July they'll be completely gone from existence.
They're fading fast.
Yeah.
Fading fast.
If only they had made a better pen device that didn't need you to leave it in a jar for
It's a little better than having to hit it on your hand 90 times like Bydureon has you do.
Well, Bydureon just redid their pen.
I was going to say, yeah, didn't they? So they're kind of getting rid of that.
We need to call them and get them to send us one, actually. We can do a video on that.
We can demonstrate.
Yeah, because I haven't actually seen one yet.
So there's, I don't know anything about it. No smacking against the hand?
I think it's supposed to be a lot easier to reconstitute.
Good.
I didn't look at it much just because I don't like the actual drug itself as far as its efficacy, so I didn't spend too much time looking at it. But yeah, it is definitely better, supposedly.
Yeah.
But it's more expensive too.
Yes.
So some insurance companies will pay for the old pen where you got to shake it 80 times and not the new one.
So GLP-1s, which I'm sure we'll mention as we go throughout, are unfortunately expensive medications, even though we really like them second line in diabetes past metformin if they can be used. But frequently they cannot. A lot of times if patients don't have insurance or it's not covered, you're going to have to go to something like SGLT2, even sulfonylurea, and maybe even something like Actos, depending on their financial status. So that is the world we live in.
Yep. I mean, it's definitely something to consider that I think that a lot of people maybe don't. When we're talking about all these new meds and this, that, and the other, it's like, well, that's all great, and it's great to know the trials, but if they can't afford it, well, what good is it?
Right. We preach in a vacuum up here, so everything's ideal world.
Yeah.
Yeah.
I prefer my vacuum.
Keeps things clean.
It does. All right. So, we were mentioning like some of the different trials that had looked at cardiovascular events.
Mm-hmm.
Semaglutide is one of the most recent ones.
Yes.
And it's also, before semaglutide was on the market, we had Victoza was the market leader. So that was the best A1C lowering, the best weight loss. And, all the other ones have been compared head to head, which is really weird because this is like one of the only classes that actually did that. Like they were just like, oh yeah, we can beat Victoza.
SGLT2s won't do it.
Yeah, no, exactly. Because they know what will happen.
Yeah.
And, they've actually compared head to head, which you just don't see very often. And so, by doing this, they've, unfortunately kind of shown which one really is truly a market leader. And so, the Byetta was definitely, that was kind of out for a while now. I mean, it's still around. Every once in a while you'll see it, but most people are on it. It's twice a day.
That's the one twice a day.
Yeah. And it's got, it's inferior A1C lowering to Victoza, so I don't really know why you'd want to use that one. Now, yeah. And now it's, older brother, the once weekly version of it, the extended release exenatide is called Bidurion, like we were just talking about. That one was also compared to Victoza. I believe they looked at it in the Duration 6 trial, and that one also did not meet the criteria for non-inferiority, so not good. And then same thing happened with Tanzium, which was also once weekly. Same thing happened with Adlixin, and then Trulicity came along and finally met the criteria for non-inferiority. So that for a long time was kind of like my go-tos. You've heard me talk about Trulicity and Victoza, like my flash briefings and stuff like that. So
and Trulicity is once weekly.
Yeah, and so I've been preaching about those for a while, but unfortunately for Trulicity, Novo Nordisk does it again and brings out Ozempic, Semaglutide, and that one is already been shown to be more effective than Trulicity as far as A1C lowering, I think weight loss as well. And now, thanks to the Sustain 6 trial, we have cardiovascular safety data with it, whereas Trulicity's it will be out probably this July. It's going to be called the Rewind trial, but it's not currently done. We're thinking July.
Yeah, and on that same coin, there's an oral semaglutide in the works. So the first oral GLP-1, those trials are the Pioneer series trials, and they're comparing oral semaglutide to liraglutide. They're doing, I think that's Pioneer 4. Pioneer 6, I'm pretty sure, is oral semaglutide versus placebo, cardiovascular safety. So that one will be pretty interesting and definitely novel in this class of drugs. As far as some other cardiovascular safety trials that they've done with other diabetes medications that are important, probably the biggest one is the IMPA-REG trial with empagliflozin, Jardiance, and then they also have the Canvas trial with Invokana. We may reference why IMPA-REG kind of turned out a little bit better than Canvas, but either way, those are kind of the three that are positive as far as cardiovascular safety goes. They also did some with DPP-4s, which, we don't really love DPP-4s either way, but they did have the Tecos trial with Januvia, not positive results as far as cardiovascular benefit goes. And then glimepiride versus linagliptin, they did a trial comparing those two as far as cardiovascular safety. Also saxagliptin, which is Onglyza, they had the SAVOR TIMI-53 trial, which didn't show benefit versus placebo with
and
cardiovascular
showed a harm with heart failure.
Yeah, harm. And so Onglyza is contraindicated in heart failure. Yep.
So, yeah, Onglyza is the worst.
The worst.
The worst, literally. So, the other thing to consider is, since we're on this, should we give a GLP-1 and a DPP-4? We've probably covered this before.
I think we mentioned it before, but yeah.
There's not really any good data that shows that those two working together are any benefit. In theory, they're on the exact same pathway. So GLP-1s, the receptor agonists like we have our synthetic GLP-1s, those are made to be resistant to your natural dipeptidyl peptidase 4 enzyme. And so you don't really need an inhibitor on top of that. They're already going to resist it themselves. And then if you are giving a DPP-4 inhibitor, then you don't also then need a GLP-1 that's a synthetic version, because now your natural GLP-1 can hang around longer. And you're really just kind of compounding side effects. You're not really helping the patient achieve a lower A1C or anything like that. So not typically used together. There was a study, an older one, that used Byetta with Januvia. It's the only one I've ever seen, and nothing I'm a fan of, and definitely won't quote it because it's not not evidence that I've really looked too much into.
Yeah, DPP-4s are basically wimpy GLP-1s.
Yeah. So you think, you're thinking about, 0.75 to 1 full percentage point A1C lowering versus only like a half, if that, with DPP-4s.
Yeah,
and that's being generous.
And GLP-1s, I think it depends also on how uncontrolled they are. If they're more uncontrolled, you could potentially see a more significant A1C benefit. But yeah, generally you're thinking around 1 or so as far as A1C reduction goes.
And originally I'd say, well, these DPP-4s are oral, so if you just are scared to death of needles and won't take one, but semaglutide's taking care of that.
Yep.
So I don't know when it's actually going to be out. When it does, I'm sure it'll be a game changer.
Yeah, it'd be pretty interesting. So that was a long introduction to get into the Sustain 6 trial, but
so interesting and good.
I know, because we're pretty awesome. But before we hop into it, I mentioned nausea, vomiting is a potential side effect. Also, there's some other rare ones like pancreatitis. So you want to be cautious, if not, avoid it. GLP-1s in patients with a history of pancreatitis. Also, it should be avoided in patients with a history of thyroid C-cell tumors. And it's very low risk for hypoglycemia. But because all of these at this point are injections, there will probably be injection site reactions more with some than others. Like Bydureon's notorious for pretty significant injection site reactions. Trulicity is pretty mild as far as that goes. So there is variability, but they can all have some.
Yeah, and also not just thyroid cancer, but if you have a history of multiple endocrine neoplasia type 2, it's also contraindicated. I don't know if I didn't think.
No, I didn't say that. Yeah, got to get those random cancers in there.
Yeah, just in case, because it's on the commercial too, so it's got to be important.
Yeah, got to be important.
I'm trying to sell myself to the commercial agency.
What is it? The FTC that regulates those? I don't think it's the FDA.
Nah.
Or maybe it is the FDA. I don't know.
Remember.
FTC does something with advertising, but
that class we took in pharmacy school, the teacher would be very upset.
Yeah, well, that whole law class that I'm gonna have to know in a couple months when I take that whole law exam thing.
Oof, it's rough.
I know. There's that. So Cole's got some reviewing to do.
I'm not trying to be a lawyer, man. Yeah, law's rough.
Yeah, apparently PharmD, people who have their PharmD and their law degree do pretty well. Apparently there's some interesting things you can do.
Yeah, I'm sure.
Yeah, got to be a special kind of person to want to do both those schools. But
yeah, I mean, obviously I get the PharmD one. That makes sense to me. If I can get my head around that one. But
right.
the JD, like being a lawyer, that's a whole different ball game with all those papers and just analytical thinking, I guess, and just in a very non-medical way.
I complain about the Naplex pass rates like dropping below the 90s into the 80s and whatnot, but I think the bar pass rates are just abysmal. I can't remember exactly, but I just want to say it's like 50% or below or 60% or below or something, but pretty bad. So, and that's not to say that law students aren't intelligent. It's to say that's just a comment on how difficult the bar exam is. So
that one guy passed it in like 2 weeks. Remember from Just Catch Me If You Can?
Oh, Leonardo DiCaprio. That's his
when
name.
Leonardo DiCaprio passed
the bar in 2 weeks.
Yeah. I'm pretty sure that's his name.
With Tom Hanks. That's a good movie.
You know that guy lives on Daniel Island, supposedly?
Who?
The guy.
Oh, the real guy. No, I've totally heard that.
Yeah.
Did we talk about this?
I have no idea.
I talked about this with somebody. No, I know exactly who it was. Never mind. It was on this past rotation. And apparently, yeah, he got out of jail because he wasn't in jail his whole life, and he lives in Charleston.
Mm-hmm. Supposed to be a super nice guy, too.
Yeah.
So, and apparently a genius.
Well, apparently.
Let's get him on the podcast.
Yeah, there you go.
I bet you I can do that.
Can learn how to forge some checks.
I just want to talk to him.
Yeah, we don't need to do the fortune checks.
Yeah, we're not doing that, Mom.
I hear podcasts where people like talk about movies that are not obscure, but just like, not recent. And I'm like, how do they know about all those movies? But you happen to bring up a movie where I actually knew two of the main characters. So Tom Hanks and Leonardo DiCaprio.
Boom. Nailed it.
Yeah.
We should start a movie podcast also.
There you go.
And it would take off so much faster than our medical one. Oh man.
Yeah.
Anyways, sorry guys. All right. So major, or I guess let's start with, we went through some of the exclusion criteria.
Somewhat.
Let's go through like the actual inclusion criteria first.
Sure.
Is that cool?
Yeah.
So obviously type 2 diabetes,
Mm-hmm.
just type 1 you were excluded. It had to have an A1C of greater than 7.
Mm-hmm.
Had to be greater than 50. And they had to also meet a certain one of the criteria that were listed, which could have been established cardiovascular disease. And that could have been either cerebrovascular, peripheral vascular. It could have been previous CV events. They also, heart failure, class 2 and 3. or CKD greater than or equal to stage 3.
Mm-hmm.
So you'd have one of those criteria.
So that's if you're over 50.
Over 50.
Yeah.
Or you could be over 60, and you had to have one of this new criteria list, which was persistent microalbuminuria or proteinuria, or you had to have a left ventricular hypertrophy or left ventricle systolic or diastolic dysfunction. And then the other one was a ankle brachial pressure index of less than 0.9.
Yeah, and so there's a lot of pros and cons to these types of inclusion criteria. So obviously, some patients are going to have established cardiovascular disease, so they don't have an ASCVD risk anymore because they have clinical ASCVD. And then there's other patients who are just high risk, so CKD, heart failure, and those sorts of things, age. So there people will kind of spit at that and say, well, we don't know if it's really good secondary prevention data, or we don't know if it's really good primary prevention data. It's hard to say. And yeah, it is hard to say. So, they do that so that you can hopefully extrapolate it into multiple patient populations, so it's more generalizable. But at the same time, yeah, that can make it a little bit confusing as to whether it fits with your patient or not. So to that, just a few baseline characteristics going along with what you mentioned. One, the average age was about 64, and it was mostly white and mostly male. Male is about 63%, white about 84%. And most of these patients were on either metformin or sulfonylurea for the most part, or they could have been on insulin. So that goes to some of the exclusion criteria, only on basal or premixed insulin, not on prandial insulin. Average A1C, even though it had to be above 7, was around 8.7, and these patients had had diabetes for about 15 years. So it's really important to look at these trials and see, does it really fit my patient when you're considering if they're really going to get this cardiovascular benefit? Because it is easy to say, hey, semaglutide, cardiovascular benefit, just give it to everybody, which, the patient may see benefit even if they don't fit exactly into these criteria, but you can't say that based on this trial, right?
Yeah. Yeah, that's definitely one of the things that people will kind of say is their criticism is, you include these studies where, or include these patients rather, that are so sick that we can't then just say, oh, well, like you said, everyone gets it then. Because
right.
There's been no way, we'd have to do the trial again with healthy patients and prove it out, but no one's going to pay for that.
Right.
Because it probably wouldn't prove out.
Right. And we said CKD greater than stage 3, but there were actually some patients. So I guess actually greater than stage 3 would mean they had pretty poor kidneys, right? There was one patient with, or I guess 0.5% of patients, which I guess would have been a few more than one, with a creatinine clearance less than 15. So some people in pretty much severe CKD, only about 30% of them had quote unquote normal GFRs. I guess that's for their age group. So they really went ahead and said, hey, bring in some patients with renal dysfunction and let's see if it works, because other trials sometimes didn't do that because they were a little concerned what might happen. So we'll get into that with the results too.
Yeah. They were like, bring them in. If worst case scenario, we'll get them some hemodialysis.
There you go.
The risk they were willing to take. So, what were the actual interventions?
Right. So it was either the patient's on placebo, and obviously it has to be some type of placebo injection or the patient's going to know they're on a placebo, or they were randomized to semaglutide 0.5 milligrams once a week or 1 milligram once a week. And that was kind of the design. It was in a whole bunch of countries, so it was multinational at over 200 sites. Median follow-up was about 2 years or so. And the primary outcome they're looking at, which is pretty consistent throughout all these cardiovascular safety trials, it's always a composite of cardiovascular mortality, non-fatal MI, and non-fatal stroke is always the 3 that they look at.
Yeah. It's convenient that they like to put them all together.
Yes. So that they can make it look better or not really worse. They can basically just make it look better.
Basically just hides the fact that it's not that great.
Right. But yeah, we'll talk about that too. And it was about 3,300 patients. So not a small trial by any means. So,
primary outcome, like Cole said, the cardiovascular mortality plus non-fatal MI plus non-fatal stroke.
It's a composite, yeah.
So that primary composite was, in fact, superior in regards to semaglutide. Semaglutide showed superiority, so, we had less likelihood of having one of those cardiovascular events, and so we can actually say that it does have benefit versus you'll see these trials where, Adlixin, for instance, they didn't get a difference. It was just non-inferior to placebo. So instead of being like, oh, shoot, we don't have any cardiovascular benefit, they spun it in such a positive glass half full way.
We're not worse than placebo.
Yeah, well, guess what, guys? We don't have any risk of cardiovascular disease, so go ahead and take it all you want. It's brilliant.
Yeah, and which ultimately that was all the FDA was asking. They just wanted you to be able to say, this isn't going to harm you, like Actose or the thiazolidinediones, or however you pronounce those. They can increase your risk for heart failure, especially because of all of the edema and fluid retention. So they wanted you to be able to say, mine is no worse than placebo, and it's not going to cause cardiovascular harm. We're just seeing that some drugs actually show benefit, whether it's intrinsic with the drug or it's because they, prevent disease progression over a period of time. Who knows? Either way, some of them do. And unfortunately, even though it did show superiority in that composite, it wasn't perfect as far as those three go, like we were alluding to. And the secondary outcomes, they kind of break those three down into their individual facets. Non-fatal MI was not significant on its own. Cardiovascular mortality was also not significant on its own. So really, it was non-fatal stroke that was driving that trio composite there.
Which is kind of similar to what we saw with liraglutide.
Yes. So that is kind of standard for some of these.
Liraglutide may have had all-cause mortality by itself as well, if I remember correctly.
You know what? Keep going and I can look.
But the stroke was actually pushing that. So, it's great to say that we have, we can reduce cardiovascular events, but more accurately, we would say it can reduce the chances of the person having a non-fatal stroke.
Right.
So, you got to be careful with the wording, and taking what they say in their composite is kind of how you present the data. The other things that were significant, we saw a difference in revascularization. We also saw a difference in retinopathy complications. And then which
was a negative difference. Right. So there were more retinopathy complications in the treatment group. Right?
Yes. Yes, that's right. Yeah, that's my bad. So yes, they were different, but it was in favor of placebo.
Right. Which is, I think, the only real negative outcome other than the nausea, vomiting type GI side effects.
Right. And, the other thing to consider, obviously we have the statistics there to kind of present the picture of whether or not something is statistically significant. But when we think of things like, non-fatal stroke, for instance, the incidence rate of having a non-fatal stroke in the treatment group was 1.6, and then not in the treatment group, or the placebo group rather, was 2.7. So you're not talking about these massive differences. It's enough to where it can make a difference when you do the statistics based on, those two numbers, but it's not something that, when you actually think about it in clinical practice, if for whatever reason this person couldn't be on this drug, you're not talking about
it's not the end of the world.
Massive life-changing thing.
Right. And, we didn't, unfortunately, but we could calculate the number needed to treat, and it would give you a better idea, which I think with that, it would have a pretty reasonable number needed to treat. But to give you an idea, so the leader trial with liraglutide, it did have cardiovascular mortality benefit on its own with a number needed to treat of 77. So that's a leader trial, if I didn't say that already. All-cause mortality, they did show benefit with the number needed to treat of 71. So that's pretty good. Empareg with empagliflozin also showed benefits in all-cause mortality with an even lower number needed to treat of 38, and cardiovascular mortality benefit number needed to treat of 45. So both of those are pretty good. So if you just compared those directly to semaglutide, where all-cause mortality wasn't statistically significant, cardiovascular mortality wasn't statistically significant, you also have to go back and say, okay, well, what were these patient populations? The patient populations, there's a lot of differences. So there's a lot of heterogeneity between these trials, even though they seem very similar. So you got to take all this with a grain of salt, but still, there are positive things that we're seeing from this trial.
Yeah, for sure. And it looks like as far as the primary composite, which again, remember, was driven by non-fatal stroke, the number needed to treat was 44 for the primary composite. For
pretty good.
So it's not bad.
So that's for all three together, which is where, the driven by non-fatal stroke, but still, that's not bad. So 44 patients, we're like, oh, non-fatal stroke. Well, that's not mortality. Well, you got to consider patients' standard of living and their quality of life going forward. And non-fatal strokes can have a significant impact on a patient's, especially a patient with diabetes, quality of life long-term and complications down the road. Non-fatal stroke, even though that's not immediate mortality, long-term, are you extending their life? Probably so. Other things that you have to consider.
Absolutely. I've noticed that I actually just throw in some random phrase when I don't know what I'm supposed to say. I just noticed I did it again. Absolutely. Or I say, yep. Okay. I'm like little John over here.
Okay.
You remember him? God, what happened to him?
That guy? Oh, yeah. We're buds.
Yeah. That's my childhood.
Oh, jeez.
Anyways, way off topic again. People who told us we talk too much about nonsense are going to be very upset.
And we're like, yeah, well, guess what? We're going to talk about more nonsense.
Yeah. Have I mentioned RX T-Rex? Whatever his name is.
T-Rex RX?
Yeah, that guy.
I don't know.
He's crazy.
Yeah, he's pretty cool.
Yeah. Can't wait to order my next one.
Yeah?
Yeah, I don't know what's going to be yet.
Don't know? No
Can't
teaser
decide.
or anything?
I saw a guy that's like riding, he's an astronaut, and he's like riding these balloons, but the balloons are really the moon. He's like,
what?
Yeah, it's pretty cool. I don't get it, but like, it's I guess it looks pretty cool though. So whatever, and it's good contrast from the, like it's like all dark as space where the moon is, and it looks good. It would look good against that wall. So I'd probably order that out.
We'll just have to figure out how to organize them. So
it
looks good back there and everything.
Plus, I shouted them out on my Instagram profile, and then they gave me a couple double thumbs up emoji. So you can say things are getting pretty serious between us now.
Oh gosh.
Oh geez, where were we? Okay.
Results.
Yeah.
Yeah.
We just finished results, didn't we?
Yeah. So safety. We talked about the nausea, vomiting. We talked about other concerns. The pancreatitis, acute pancreatitis, which I think is a little bit overblown with the GLP-1s, was fleshed out in this trial a little bit. Placebo group actually had a higher incidence of acute pancreatitis, so we're really not too concerned unless you see a patient's trigs upwards of 500 or they have a history of it. That's really where you're thinking, okay, GLP-1 might not be the best option for them right now.
Right. I thought that was interesting that hypoglycemia was like almost the same in both groups compared to placebo. Yeah,
and that goes to what the mechanism that you were talking about before. We're really this and metformin, we're not really concerned about hypoglycemia, and that is huge, especially in the elderly population.
Yep. And it's also good too, because if you have a patient that is having to check their blood sugar, obviously, then it's they're more controlled, they're not on insulin, then you can still only check like once a day, sometimes even like once every other day, because you're not having to check pre-prandial or post, or the 2 hours after the meal, post-prandial, because realistically we're not really worried too much about hypoglycemia.
Exactly.
And if you find out that your blood sugar is a little bit high after a meal and you're on metformin and a GLP-1 once weekly, what are you going to do about it anyway?
Right. So unless you just want a reference point, but really, so if they're on basal insulin also, then really it's just fasting that you got to focus on at that point.
I think the only time that I go against that is if they're saying they're taking their medications and they're still uncontrolled, because I'll get random blood sugar readings to figure out where they're kind of losing their way as far as the diet.
Right.
That's where you would use it. So I do want to specify, because I'm sure there's someone here who does diabetes education and they're like just losing their mind. That's the wrong thing to say.
Right. Not saying the patients don't need to check their blood pressure.
Yes.
I mean their blood sugar, but not like they would have to with with pre-prandial glucose. That being said, I have seen patients who are on basal insulin, bolus insulin, and they're on a GLP-1, which I think is interesting. The idea is to decrease the insulin requirements, because we know long-term insulin is going to cause increased weight gain, high risk for hypoglycemia, maybe even some cardiovascular issues. I think there are some cardiovascular safety trials out there for insulin, but there is still that potential.
Origin was one of them.
Origin, yeah, that was definitely one of them. So that's something to consider. And in that case, yes, you would want to have a pretty good idea of what their postprandials are looking like if their fastings are definitely under control.
Yeah. I knew a guy who he was well controlled. His A1C was like probably lower than I would want to see it. And he had gone to go with like a complete unrelated surgery. It was like a in and out surgery type of thing, and the anesthesiologist was asking him how often he checked. I don't know why he was doing. I guess he was just talking small talk with him, but asked him how often he checks his blood sugar, and he said just once a day, sometimes once every other day. And the guy was like, "No, man, you got to be checking it 4 times a day, 5 times a day." And he called me, and he's like, "Is this true? Like, why would I?" It's like, "No, that's not true." Like, what are you gonna do with 5 times a day readings? Like, your A1C is perfect, probably too low. I think you're okay. I think that guy's just confused.
Yeah, and that's something you have to consider, because I think that some people have the misconception that all patients with diabetes need to be checking every morning fasting and then after every meal every day. But if a patient's well controlled, they may not need that, and you have to consider the burden that that's going to put on them. So they're already having to potentially inject themselves every day, at least take medications every day, which reminds them that they have diabetes. If they have to stick a lancet in their finger and check their blood sugar before, after, or fasting, whatever, every day, the more times they do that, the more they're reminded. And, in these chronic disease states, depression is an issue that you're going to have to deal with, or at least the patients are going to have to deal with, and you'll have to be aware of when you're treating them. So that can just add to that, because they already have a significant burden with the diabetes in general.
For sure.
I think that's another one.
Yeah. Listen, don't call me out of my...
You pointed it out. Now I'm all focused on it.
Just because I need filler words to make myself sound...
if we counted the ums, we probably shouldn't point that out to people. Then all they'll be able to focus on is us saying all the time.
No, they'll get over it.
We'll see.
Maybe not. So that is Sustain 6.
Mm-hmm.
So hypothetical situation. We got the guy, some random person has diabetes type 2, and they are on metformin max dose, and they're on a GLP-1, and let's say they have cardiovascular, so ASCVD, and they're not on a statin. What are we going with? I know this is not related, but let's just, whatever. We're making stuff up now.
I think I may have blanked halfway through that, so you tell me what we're going with.
So a couple ways to think about it. One, we know that a statin can help patients, specifically with diabetes, because of the CARDS trial, which looked at atorvastatin 10. And then from there, they looked at, especially patients with secondary prevention, they looked at patients that were taking 80 milligrams versus 10 milligrams in the TNT trial. And the 80 milligrams was better and reduced secondary events. So it's one of those things that I would potentially go all the way up to an 80 milligram dose of atorvastatin for this person if they weren't on a statin, had ASCVD. I've always found that it's easier to tell the person you're cutting their dose in half if they start talking about myopathies or myalgias or anything like that. And then you can kind of say, okay, well, we're cutting it in half. Whereas if you have them at 40, they're tolerating it, and you say, okay, now I'm doubling the dose. I feel like psychologically that just sounds worse.
No, I agree. I think we actually referenced this a little bit back in the stroke podcast, or the post-stroke podcast. But that's a good trial to say, let's just go straight to 80, because a lot of clinicians, prescribers will want to kind of start low and go slow. But that's one of those where post-stroke, it's okay just to pop them right with that 80 milligram dose. It showed benefit, and then if they have symptoms, you can just start to back off from there, which again, I'm sure I said in the last one, but the symptoms are a lot less frequent than people think.
Right.
So don't freak out about it.
And also just to kind of add on there, it's ischemic stroke. I don't know if I heard you say ischemic.
No, I just said post-stroke.
But yeah, so ischemic stroke specifically, hemorrhagic stroke actually was didn't get the same benefit as ischemic. So
right.
Person has ischemic stroke, that's when you hit him with that atorvastatin 80 milligrams per the Sparkle trial.
There you go. Cool.
So yeah, just thought I'd throw that in there.
Yeah, that just goes
time waster.
Goes to the point that cardiovascular events are frequently what kills these patients. If it's not an infection or a foot infection, something of that sort, or a fall, a hip fracture from a hypoglycemic event, a lot of times it's something cardiovascular. So anything we can do to decrease that is important.
Did we talk about the new ADA updates where they change their recommendations if the patient has ASCVD?
I think we did a whole podcast on it.
I think we, yeah.
Probably. Or was that just hypertension?
think we did hypertension.
Okay, no, yeah.
I don't know.
No. Sorry, we did hypertension on the ACC/AHA guidelines.
Yeah.
So tell me about the ADA guidelines.
So we used to just say obviously everyone starts with metformin if you're a type 2, and then from there, unless you had an A1C of 9, 10, up there, that's when they would move to insulin. But if not, if let's say it was an 8, then they would basically just say pick whatever agent you want to use second class, and they listed off GLP-1s, sulfonylureas, DPP-4 inhibitors, TZDs, whatever. And so you pick which one you wanted to go and just pick one at random, and then you would work your way down the list from there. So one of the updates for 2018 was whenever a patient is looking for a second-line agent, so they're already on metformin, they need a second-line agent, you assess whether or not that patient has ASCVD currently. If they do, and I think, I don't have it in front of me, but I think if the risk also
if they have a certain risk,
7.5 or 10, it's one of those two, I can't remember. But if it's that, then they will use an evidence-based treatment option, and that's the 3 that they mentioned specifically is Victoza from the LEADER trial, Jardiance from EMPA-REG Outcomes, and then Invokana from Canvas
trial. Yeah, and now it seems they don't put it in there, but it would seem that Ozempic would be a reasonable option in that case too.
So we'll see. They may update it in very beginning of 2019 or December or something, but we'll see. Definitely curious how that plays out.
Yeah, for sure.
And I cannot wait for the oral version.
Pretty pumped.
It's gonna be
pricey.
Yeah, it is. And also in type 1s too. There's been some minor studies looking at GLP-1s in type 1s that have showed a little bit of benefit. So they're small, and I don't know if it's actually going to show anything in the long run. But
they gave that a shot with metformin, and it doesn't seem like people are wanting to catch on either.
So funny story.
Mm-hmm.
When I first got licensed, I was working with the diabetes patients.
Mm-hmm.
I hadn't quite established my knowledge. I was still in the learning phase, still, trying to build my knowledge as I was going kind of in the middle of it. And I had a patient that was a type 1, and he was on Onglyza.
Mm-hmm.
And which I thought was strange, but me being new at this and thinking that I'm going to spit some evidence-based medicine, then I was like, well, let's not do Onglyza. Let's switch him to a GLP-1, because Trulicity, and I had the whole thing listed out, and the prescriber just like cracked up laughing in my face and basically was like, yeah, that's for type 2s. You can't use that in a type 1. And I was so like thrown off because I was so new at this, I didn't really know what to say. And now I've been like, oh, you already have them on a DPP-4.
I was going to say, why are they on a DPP-4? But
you must be kind of stupid. And so I wouldn't say that.
No, we love other professions. We don't say things like that.
No, unless we're in a really bad mood. But no, it's now I would be able to be like, well, what are you talking about? I'm just trying to help him out. If you're going to try experiments on him, let's at least give him a good experiment. But yeah, at the time I was like, oh, I'm so stupid. And then when I got home, I was like, no, DPP-4s, what was I thinking? I totally blew my opportunity to come back. Oh, man. So, and it's haunted me ever since.
Clearly.
No, but it was good. It was a good learning, opportunity for me to be like, okay, you get super, super serious about constantly trying to learn, because that stuff, it didn't come, that fact didn't come to the surface right away, and I was really mad at myself.
Yeah.
So it's a good life lesson. It happens.
It happens to the best of them.
Mm-hmm.
I mean, that guy had him on a DPP-4. So.
I don't know what he was thinking.
Yeah.
At least mine was evidence-based.
Oh, man. And on Onglyza of all of them.
Yeah, I know. What a mistake.
I know.
That was so unevidence-based.
We love physicians.
Yeah, we really do. I'm glad I don't want your job at all.
It is. No, it's a crazy tough job.
Yeah. I was joking with my students that they mentioned something about the anatomy. I was like, I don't know. I just know the shoulder, because that's where we stick the needle.
Right.
That's the only thing
the deltoid. We got that one.
The shoulder region.
Right.
And then it's connected to the upper shoulder. And that's it. That's all the anatomy I need to know. I was like, don't ask me that. Ask me drugs. That's what you guys are for. That's why I call you guys, and you guys tell me about the diagnosis. I don't know gross anatomy. I took baby anatomy in undergrad. That's it.
As did I.
I'm not really sure that the guy was telling me the right things.
Yeah, they pronounce stuff like duodenum and whatnot. What's up with that?
I don't know. Undergrad.
I know.
So silly.
Anyways.
Cool. What else? Anything else we need to discuss before we get out of here?
That's all I got for that trial. I think that was cool. We might do more of these every once in a while where we start micro, grab a trial, and then kind of branch out from there and see what else we can make up as we go along.
Yes, sounds good to me. Also, I think we may try to. We haven't discussed this. This is just me thinking, but
I love it when we do that
yeah.
in the middle of the podcast.
Yeah, for sure. This is us planning. This is how it goes. I think we should probably try to do like another patient case. It combines a few different disease states. Try to knock through one of those and put the case itself on the website. And it may be, just maybe, there may be like an Alexa skill that helps you learn these trials.
Teaser.
Coming soon.
Whoa.
And by soon...
Soon is a relative word.
And by soon we mean we have no idea, but we're trying real hard.
It'll be interesting. No, I think it'll be really good.
Yeah.
I think it's going to be cool.
No, I'm excited.
Yeah.
I'm going to dominate.
Yeah. So you may just be able to say, Alexa, tell me about the Sustain 6 trial. Mm-hmm. And then within the next 2 to 3 minutes,
you have one of our majestic voices coming across Alexa.
And you know everything you need to know.
Or at least 1 minute worth.
Or at least 1 minute's worth. You can look up the rest.
And then you can look up the rest by yourself.
Yeah.
I'm not going to do everything for you. But so that's probably going to be coming soon.
Cool.
Also, for those of you who live in Charleston, I'm going to do a selfless plug here.
Ooh, we're plugging.
Yeah, this is an event that is going to be for continuing education for physicians, nurse practitioners, PAs, and PharmDs. It's going to be on May 24th through the 26th, and it's the evidence-based conference hosted by Dr. Wayne Wirt and Dr. Scott Bragg from MUSC. They put on a really, really good conference, and they have tons and tons of very skilled and seasoned clinicians coming in to talk about all kinds of different things, update you on everything from asthma, COPD, glaucoma, all kinds of stuff. And then believe it or not, I bribed enough people, and they're actually going to let me get on that stage too.
They're letting you do that?
Oh my gosh, I know.
What are they thinking?
Then they're not. And I think Dr. Ward just felt bad for me. And so, I'm going to get up there and we're going to talk a little bit about staying current with medication trends and things like that. So I would highly appreciate anyone coming out and hanging out while we get up there and spit some evidence-based medicine. It's going to be a really cool conference, and definitely want to support it. And Dr. Bragg and Dr. Ward did a really good job, and they do this every year. And so I want to hopefully get them a big crowd. So if any of you guys need CEs, please come check it out. And it's like a discount for students too. I think it's only like $150 for 3 days, 3 solid days of CE, I think, if you're a student. So it's pretty solid.
It's pretty great.
So, all right. Well, till next time, Cole, take it easy.
You too.
Podcasting world.
Yep.
You also take it easy. We'll see you.